Good evening, everyone. Welcome to another webinar organized by Collaboration and My Osteopathy. Today we have the pleasure to have Christian Lunghi with us, and we have a slightly different format for the webinar that I'll explain you in a second. Okay, so let's start with our typical introduction. So today we're going to talk about osteopathic models of structure function, and we're going to try to approach this from a critical perspective, with the sorts of some kind of thought-provoking questions. Do they need to be updated or dismissed? So the idea is really to generate, a debate. A little bit about Christian. So Christian is an osteopath practicing in Rome, is a council member of the Italian National Center for Collaboration, is an author of several books, and in particular the osteopathic, the 5 models of osteopathic care. So translated now in a few languages, as far as I know, a few peer-reviewed papers as well, and is also a member of the academic board of the Malta International College of Osteopathic Medicine International. So the format of today, as I said, slightly different from the previous ones. We'll have Christian presenting, and at the end of the presentation, we will have a debate. And the debate will be, with myself, Christian, Francesco, Cerritelli, Paul Vaucher, Patrick Van Doon, Rafael Zegarra-Parodi, so all the members of the Board of Trustees of Collaboration, and some other members from the national centers like Sonia, Roura from Spain, Chantal, Morin from Canada, Tameem, Mohamed from Gulf, and Oliver Thomson from the UK. And, I'll ask them to introduce themselves in a second. What we will do, so after the presentation, we'll put some questions up and we'll start the debate. And the idea is for each question, 2 of the panel members will almost like present the pro and against the motion. And after we've done, we go through the 4 questions in total. After those questions, we'll ask you guys to just write a few questions on the chat area. And then we'll select a few things that haven't been addressed yet, and then we'll continue the debates, including you guys, as much as we can. We have another one. So since last time, we managed to organize another event. The next one will be on the 31st of May with Rafael on body, mind, spirit in osteopathy. I keep reminding you guys, and I hope that we can have the conference this year, and I hope to see you guys there. So we'll run our Quantum Global, so the Collaboration Annual Conference in Paris on the 2nd and 3rd of October. And if you've got any research projects, any piece of work that you might want to disseminate, to the community, please submit your abstract. And again, showcase of our work, collaboration, a number of projects from research to volunteering, sort of humanitarian work, and some other kind of community-based projects. So I'm going to pass now over to just ask a few of the guys to introduce themselves very quickly. So just ask them to switch on the cameras and come on, say hello, and then say goodbye. So we can start with Tameem. So just an opportunity to, you keep on. Stay on, Christian.
Okay, hello everybody.
Oh, thanks, Tameem. Let's just, hang on, Christian, let's just, introduce the members of the panel and then we'll continue.
Yeah, no problem.
Okay? If this works, if it doesn't, that way we skip that stuff.
Okay. Hello, George, how are
Hi,
you?
Tameem.
Hello, everyone. So thank you for this webinar today. My name is Tameem. I'm a registered musculoskeletal physical therapist and osteopath. I graduated from the European School of Osteopathy in UK, and currently I'm working in Riyadh as an osteopath and also academic advisor for Mayo Academy and Mayo Osteopathy. Thank you.
Thank you. See you soon. Patrick.
Good evening, everyone. Good evening, colleagues. I'm Patrick Van Doon. I'm an osteopath in Belgium and in Germany as well, and I'm a member of the Board of Trustees of Collaboration. Have a nice evening.
Okay, Francesco.
everyone. Thanks, George. Francesco Cerritelli, osteopath and neuroscientist. A bit crazy, a bit eclectic, and I'll be very big to be to be part of the final debate. So have fun with Christian, and see you soon.
Okay, Paul, thank you.
Hi everyone, I'm Paul Vaucher from Switzerland. I'm head of the Unit of Research in Mobility in the University of Applied Science, where I also hold the position of School Professor, and I'm really happy to be here with you tonight.
Okay, let's do the ladies. Sonia.
Good night, everybody. My name is Sonia, and I'm running the Com Collaboration National Center in Spain together with my colleague Gerard Alvarez. Thank you to invite me to this debate, and see you later.
See you later. Chantal.
Morin, Quebec, Canada. I'm teaching in rehabilitation and osteopathy, and newly involved in the NACE in Canada. So welcome.
See you soon. Rafael.
Osteopath practicing in Paris, and I'm also a member of the Board of Trustees of Com Collaboration, so enjoy the lecture.
Okay, and finally, Ollie, before we move to Christian. Oliver.
Thomson. In the UK, I work as an associate professor at the UCO. Most of my teaching is on evidence-based practice and qualitative research, and I'm looking forward to the discussion.
You have a great microphone.
Yeah,
You're going to sing to us at the end. Okay, good. Thank you. So let's start with Christian now.
Hello.
And enjoy, guys.
Thank you. Thank you to invite me. I appreciate that. Hello, everybody. It's a pleasure for me to share with you some ideas, some knowledge, and most of all to talk with you at the end, to share some idea to move on with the renovated role of our profession, of osteopathic profession, most of all to answer health needs and the quality of health service. I'm going to speak about the 5 osteopathic structure function models, and we briefly speak about the origins and evolution of the concept. We go deeply into the contemporary debate on theoretical model of osteopathic care. Then I briefly try to describe my mindset in practice, in clinical practice, with all my cognitive bias, so we can discuss about that a little bit later. Then we move on with the debate, discussing our future challenge to renovate our theoretical model to improve our osteopathic care in practice. Well, briefly about the origins of and the evolution of the concept of the 5 models. All of you knows that the whole doctor Henry Taylor Steele spoke more in terms of regional anatomical approaches. He described in his first books 5 regions that were considered the cause of all diseases and symptoms in patients. He also spoke in terms of neural irritation and fluids obstruction in the body to be addressed by the osteopath thanks to osteopathic manipulative treatment. And those functions were then a little bit discussed with the first osteopaths, such as Little John, as you know, Louisa Barnes, and others. And they start speaking about the interdependence between body regions and functions that were considered as involved in the disease processes. Today, if we have a look at the definition of osteopathic model in the glossary of osteopathic terminology, we found that the osteopathic models are also described as treatment approaches to address physiological functions that maintain health and play a central role in adaptation to stresses, as well as in recovery and repair from illness and diseases. So today, we think about the structure-function model more in terms of adaptive models of osteopathic care. So the 5 models are more used as integrated to articulate the approach to influence a patient physiological process of health. In other terms, homeostatic, allostatic processes to favor the adaptation to environment challenges. The contemporary debate about that, it's quite alive today. For instance, a paper from Smith in 2019 focused on our practice that, in the word of Smith, is a little bit unbalanced today. The focus of our practice is definitely unbalanced. And on the one hand, we have what we call a biomechanical approach or biomedical approach that is a little bit more operated-centered approach. It's a more tissue-based approach, we can say, and we can also put into that kind of model approach also the concept, an old concept of somatic dysfunction and an old view of the structure-function model, where a structure is viewed as a cause of a functional or of a functional maladaptation or of a disease. On the other hand, we have the more psychosocial approach that is more, let me say, person-centered and is focused on psychosocial approach and educational approach, and sometimes on hands-off approach. In the word of Smith, the community of practice has to, it's now time for the community of practice to support an integrated model of care, of osteopathic care, between that two pole of the story. Then, of course, if we speak in terms of contemporary debate about the theoretical model, we have the recent editorial from Esteves and colleague from the board of trustees of CAM Collaboration. They've done an admirable work in focusing some cognitive bias and some anecdotal ideas still present in osteopathic practice. And they also speak about the somatic dysfunction concept and also about the 5 osteopathic models, considering them as grew up by an expert, the expert consensus, and they say that can be used cautiously in practice in absence of a better model. I just let you reflect, self-reflect about those 2 questions I want you to reflect on. Did you study structure function models in your osteopathic training, or for instance in your progressive continuing education programs, just reflect and maybe write in the chat so we can know something about you. Just a few seconds. Well, today, as a health profession, we have to be most evidence-based healthcare, they say. But if we have a look at research in that topic, primary clinicians doesn't work properly in that way. So the real world, it's a little bit different. Some authors report that primary care clinicians work in community of practice, combining several information from a wide range of sources into what they call mindline. You can also say mindset. They define mindline as internalized, collectively reinforced tacit guidelines, which the clinician use to inform their practice. So, in other terms, a few clinicians used to read research and integrate directly in practice. Most of us just follow opinion leaders. Maybe the opinion leaders read research and integrate research, interpret research, and report to the community of practice. And in that shared model, the mindline grew up. And today I'm here talking to you about my mindline with all my cognitive biases, but in that way you can recognize, for instance, some ideas, maybe right, maybe not, and also some bias that altogether as a community of practice we can correct. Maybe. Starting from the beginning, from our outcome, health, we have to find health. What is health? Everybody of us, we know that health we can consider a dynamic process to adapt to the environment challenges. We can also say to adapt to stressor. The environment challenges, every one of us, we have to decode before to adapt that. And in that picture, the environment challenges are represented by a spider. Maybe a spider could be good friend of some of you, but some others don't like the spider. So when we met an environment challenge like a spider, we process the stressor by our belief, by from biological and neuroscientific point of view, by the intrinsic connectivity network, and also by our interoceptive system, by our predictive system. Then the responsiveness of adaptation is implemented by sympathoadrenal system and hypothalamic pituitary adrenal system that after the decoding favor the homeostatic allostatic reactions. And self-regulative homeostatic allostatic reactions are summarized in osteopathic practice as musculoskeletal and tissue remodel reaction that we call biomechanical reaction or self-regulation, also by neurologic pathway, and so neurologic responsiveness, also by circulatory and respiratory responsiveness, as well as metabolic responsiveness, and so on, with psychologic reaction to the environment. All these self-regulative processes has an impact on tissue remodeling that we can call tissue adaptation. And also maladaptation has an impact on tissue, and we can have so some secondary outcome in tissue that we can see as elastic deformation, so reversible changes in tissue. And when we have anatomopathological signs, so when we have disease, we can have a plastic deformation in tissue that is not reversible. So my speculation is that what osteopaths palpate and call, for instance, somatic dysfunction or fascial pattern, they are palpating maybe tissue strain or elastic deformation, reversible. And I hope this palpation is emergent from a shared decision-making with the patient, and is might be related to adaptive and regulative processes in all the body of the person. Osteopathic palpatory fighting in that way has not been seen as the cause of the disease, cause of the symptom, but most like osteopathic patient interface to favor biological and psychological effect of touch. Going into the structure function model, when we speak about biomechanical model, the osteopathic focus, as you probably know, is to improve musculoskeletal movement, musculoskeletal and fascial strain, also enhancing motion, postural balance, and pain. In the neurologic model, the osteopathic aim is to balance neural autonomic pathways, as well as modifying functional connectivity patterns. Also, the focus is to enhance cortical processing areas of interoceptive and attentional information, as Cerritelli show us in the last few works, or Tamburella in 2019. Another focus of the neurological model is to, of course, to relieve from pain. The respiratory circulatory model focus, osteopathic focus, is to improve breathing pattern, body fluid supply and drainage, also improving cerebral perfusion and vessel stiffness. Let's do an example. I quoted also another time Francesco Cerritelli down there, vessel stiffness. Cerritelli 2011 was a paper, if I remember well. The aim was to evaluate the impact of a tailored osteopathic treatment on patients with hypertension. Well, of course, the outcome was hypertension, but was also the vessel stiffness. The vessel stiffness assessed with laser Doppler, if I remember well, and they found improvement, well, in hypertension, but also in that self-regulation aspect that is the vessel stiffness, that is not the disease properly. It's something more about a maladaptation of the cardiovascular system. And they found that the osteopathic treatment is effective also at 1 year follow-up, if I remember well, but later we can speak about Francesco. Then the metabolic model, the osteopathic focus is to enhance immune system function, endocrine function, and gastrointestinal function, and in its capacity to absorption and disposal. Then the biopsychosocial model, the osteopathic focus is to improve lifestyle, to use mind-body practice and stress management, as well as spirituality, and practitioner messages are focused on improvement on patient adherence, paying attention at nocebic communication. Again, just a few seconds for you to self-reflect with this question in mind. Do you use structure function models in your clinical practice? Of course, you can write in the chat something if you want, then we speak later. Well, an example of how I select and integrate, I would say mostly integrate different models to program a treatment plan. Well, let me say, I do my clinical history, as all of you, and I take some information from clinical history, and I weight that the information, I put the information into the column, the second column, trying to weight the aspects, the functional overload related to patient presentation. So, for instance, a family disease, I process and put into the box of one model, or past medical history of a patient. Also, when I do my review of systems functionality, when I think about patient physical activity or habits or lifestyle, I put the responsiveness of the patient, the answer of the patient, into the box of the model, of the different model. Then I weight and I evaluate which is the weight of the different body system overload related to patient presentation, to patient chief complaint. And I use that to select a biomedical physical examination of a body system. For instance, if I choose a biomechanical, because it appears, it is the emergent pattern of a body system more important for that patient, together with the biopsychosocial aspects, I select a biomedical physical examination of that body system in particular. And that biomedical physical examination of body system I use to process and to evaluate the clinical relevance of osteopathic palpatory findings that I evaluate with my osteopathic physical examination. Let's do an example in practice. Just have a look at that, those few data about a patient, a lady, 55 years old, retired work officer, presented to me with chronic left shoulder pain. It's chronic pain, and he presented to me with a secondary event of pain. And I just with this few information, I process in the way I tell you before. So I tried to take some information, for instance, allodynia in the thoracic outlet bilateral, or for instance, sleep disorders associated, anxiety, or for instance, the precedent secondary events improved by after mindfulness exercise, for instance. And I put into a box neurological, biopsychosocial, and so on. And for instance, in that example, the patient showed me, you can see in the left column, an high allostatic index observed with biomarker, psychomarker, and life marker. If you are not comfortable with that biomarker, we speak of some information you can have from blood analysis, or from, for instance, if you use that heart rate variability, psychomarker. We have a few allostatic index questionnaire, life marker, are scales you can use to evaluate, to assess the impact of life events on stress level. And in the other column, you find the objective examination finding related to chief complaint. So in that case, left shoulder, frozen shoulder, I choose NIRS, Hawkins, and Yoakum test, as probably all of you has done. And as body system functional examination, just because the information I gave from the patient narration, I choose a neurologic assessment, for instance, a manual assessment test of central sensitization that was positive. So that it was, I found from narration some information about central sensitization. I had the intuition of maybe there's a neurological overload, and I assess with the battery of tests concerning the central sensitization and autonomic nervous system tone. Also, because I found some information that let me think about psychosocial impact on patient presentation, I choose the Waddell signs, so a battery of tests that could confirm in practice that there is a biopsychosocial aspects in that presentation. And if you have a look in that decision-making process, we have some decision-making moderators, for instance, the allostatic index, that I can use to evaluate during time, during the treatment plan, the effect of osteopathic treatment. Is going well, is not going well, and I use it during time. The objective examination finding related to chief complaint, the body system functional examination, as well as the multidimensional aspect of patient perception down in the table, such as familiar symptoms that could be some uncomfortable daily activities self-perceived by the patient, or perceived thanks to the osteopathic evaluation. I use as decision-making directors, not moderators, but director, because they can drive, if you met some of them, they can drive your decision into your algorithm to plan a treatment. And to process, for instance, osteopathic palpatory findings that in my mindline, in my mindset, are not just structural changes in tissue. When I found some structural change in tissue, I try to process in practice with that decision-making drivers or directors. For instance, thanks to some provocative tests. So I try to assess if a particular somatic dysfunction, for instance, in that case, M9907, it's an upper extremity somatic dysfunction, or rib cage somatic dysfunction, that in that patient was more about the thoracic inlet, first rib, something like that, or Simpson fascia, more generalized, I process that information, that tissue change, by provocative tests to evaluate if in the immediate moment I found some changes in the body system functional examination score, or in the objective examination finding related to chief complaint, for instance, the NIR, the Hawkins, the Yocum test, and also if I found some changes perceived by the patient, and in particular, in the uncomfortable daily activities we found together during the assessment. In that way, so I put into my decision making some moderators, some directors, some sign, some narrative of the patient, and I can also self-reflect on research finding on similar contexts, on similar clinical contexts, to select the proper tailored approach. And in this table you can find some specific approach. When I say specific approach, I speak more in terms of approach aimed, focused on an area, on a somatic dysfunction. And you can also find some systemic approach. When I say systemic approach, I speak more in terms of the osteopathic approach that are aimed to address function, not aimed to be focused on a somatic dysfunction, but more aimed to address a function. For instance, I can say a lymphatic pump, a general thoracic lymphatic pump, for instance, that in the table I put into the general osteopathic treatment in the circulatory model, for instance, as an example. And if we come back at that patient, so I put some information about clinical history, some information about the allostatic level that in that patient was high, and the information about the central sensitization to select a systemic approach, let me say in the neurologic field, more oriented at that type of touch that we can use to balance autonomic nervous systems and to decrease the central sensitization. So let me say an interoceptive approach, more an interoceptive osteopathic approach. Then I put just because I had other information such as the clinical history and the vital signs driving me through the idea of biopsychosocial aspects on patient presentation, involved in patient presentation, I use some, let me say, patient active approach that I put into the biopsychosocial model. And so I use some mindfulness exercises and, for instance, some intentional breathing integrated with that osteopathic approaches. And also in that session, I balanced the responsiveness, the autonomic responsiveness of the patient. So I also use some specific techniques to assess, to address the, let me say, the fascial compartment in the upper extremity that was affected by a radiation in the patient, with a typical type of touch that I use in the neurologic model. So I use the decision-making drivers or directors also to select with the patient the area or the pattern we use in an active approach, and we select together in a shared decision-making. And also I use some, let me say, symptom-based approach that I can select from the database, from the research, from self-reflection on the research on similar clinical context. To summarize, a conceptual model provide a framework for the organization of the knowledge of the discipline. It determines the distinctive focus of the discipline, also serving as a guide for observation and interpretation. Let me focus a little bit on the word distinctive focus, because sometimes when we speak about theoretical model of a profession, we speak more in terms of interprofessional model, and this is good. It's okay. More in terms of model that are shared with all the health allied profession, and that is okay. But we have to remember that a conceptual model has also to be distinctive, that also have to describe the distinctive role of the profession to answer health needs and the quality of health services. And that answer, that proposal has to be different from other profession. Not in all, because we have also some interprofessional activities. And in my point of view, in my discussion tonight, in my ideas, in my mindline, let me say in my mindline, if we move on through a more shared decision making with the patient and other professional, as the renovated structure function model allow us to do, we can also balance the evidence results to use in practice with patient needs. And if we will be more focused on the health processes, let me say homeostatic, allostatic processes, the processes of health, maybe we can balance that two aspects, the bio aspects and the psychosocial aspects. So in my point of view, we can say that we use a biopsychosocial model. It's okay for me, but the word bio has to be inside the concept of mechanical aspects, neurological aspects, metabolic aspects, and circulatory aspects, together with the psychosocial aspect or the psychological aspects, the psychological responsiveness to the environment challenges. Speaking about the future challenges, let me say that again, that Esteves and contributors gave us a great gift as a community of practice, because they wrote down a roadmap, a research agenda to build up a more powerful theoretical model, because they say to us that maybe firstly we have to recognize the state of art. We have to do some scoping review to overview what is known around the theoretical model in the osteopathic field. Then, as a second step, we have to generate a first draft, maybe thanks to qualitative research. Maybe we have to draw up a grounded theory. Then we can confront that model, that grounded theory, with experimental research with the falsifiability. And then we can identify strength and limitation, for instance, with some content analysis or consensus study into the community of practice. And finally, we can do some implementation in practice and also in the education field. I let you just think a little bit more about structure function models, and as we prepare our debate all together, you can just reflect on osteopathic structure function models that maybe has to be updated, and if yes, I ask you how, or maybe has to be dismissed, and if yes, what could be adopted instead of. And thank you to be here. I'm done.
I know. Thank you very much, Christian. Okay, it's very good, thought-provoking presentation, and I'm sure people will have lots of questions. So let's move to the next stage of the webinar, and we'll come back to some of the questions that you guys have posed in the chat. So let's pull this to the next round, okay? Okay, almost there. Okay. Come on. Oh. System is slow. Yeah. Okay, it jumps straight to sleep. Come on.
Okay.
Let's stay there for slide 3. Yeah, that's fine. Okay, so the other slide basically was just a little bit of background, which Christian has kind of presented, which is our recent editorial. That we sort of called for a little bit of a debate. Some people may have felt a little bit uncomfortable about the editorial. That's good. Okay, it's good to be uncomfortable, because that makes us sort of move forward, right? So kind of, if we think about, not in a fixed mindset, we need to improve, we need to sort of ask the big questions. I think that was the idea. It's just to stimulate some debate. So, we've got now 4 questions that form the basis for, our debate now with the other participants. So what I'm going to ask, guys, is, let's do the first question. I'll ask Francesco and Rafael to join, and Christian to step aside a little bit, if you don't mind, and we're going to address the first question, so see you in a second. So the first question is this big question about function. What does really function mean? Is it purely a biological aspect? Does it sort of, involve other dimensions of the patient presentation? So let's get some debate. And I would start with Francesco, very much from a kind of a physiology, neuroscience perspective, kind of to bring the, what one would describe as function from a kind of a, I guess, physiological, scientific perspective. And then we move on to Rafael. All right, Francesco, the floor is yours.
Thank you, George. So you can expect that also from the environment that Rafael created. So there might be something additional to the just a biological function so far. So sure. I have a poor, let's say, pure light, and on the other side there's kind of Amazonian effects. Anyway, now what is function? In addition to what actually Christian introduced, the idea of function might be viewed in a way that is a means to outcomes, to a specific outcomes. So, from a biological point of view, the use of the function creates specific outcomes. So the cell can move. The neurons can fire, and therefore since they fire, they create a function, so a biological process that produces that specific outcome. Now, in biology and neuroscience, it's quite clear. Because actually we see different processes. So we see the structure that is the anatomical elements. Then we see the function, so how they work, and then we see the outcome, so firing or creating a network between neurons. Now, what is interesting at this point that in the osteopathic world actually was used this assumption to justify the fact, so they transfer this biological content and the biological explanation to justify what actually is happening in the clinical practice. So they just use, as we step back, we saw the vision, and we use exactly the same pathway to justify something that we are doing in the clinical practice in a way of justifying the reason for something. What happened? That sometimes in biology, in neuroscience, and so on, we need proof of concept, and we need to objectively prove that something is working, so that that function is the means, the real means to that specific outcome, or that structure that might or not be related to the function can create that specific outcome. In osteopathy, instead, actually was something slightly different, that is related to the fact that our mindset, so our proof of concept, is to create the way that we need to prove that our treatment worked. And therefore, our line was, yes, since we saw the outcome, so the patient improved, therefore there might be that specific or our specific or our idea that is specific from a biological structural point of view, actually that happened, and therefore we saw the outcome. That is extremely clear at the beginning of the century in osteopathy, is extremely clear right now when actually you talk with someone or with people with a specific attitude in justifying what they are doing. The critical point, therefore, is to merge the two things. So and creates the ground to understand what are the gaps in between the two elements, and therefore introduce something that might be over the biological function. So I'm a fan of obviously the neurobiological function, but I recognize the fact that it might be also something else that can influence the biological elements, but again, the outcome is going to be still from a biological point of view.
Great, thank you very much, Francesco. Rafael, add something, please.
So thank you very much, Christian, for this wonderful presentation. I will probably add a couple of things. There's obviously a wide range of practice in osteopathy, and as just Christian said and described, there's a lot of practitioner can focus more on the musculoskeletal system and trying to target to get more specific effects, and at the opposite range we can have more focus on the person rather than the body, and trying to get more non-specific effects on when Christian talked about interoception, and I'm sure Francesco is much more appropriate to give details on that. So I would say it's more this debate between structure and function is more about promoting critical thinking, and that's the most important, rather than just grasping one and that would fit for every patient, for every type of practitioners. And one thing that maybe Christian would add, what are the representations, what are the values of osteopaths? Are they considering more as they think themselves more as musculoskeletal therapists? So in this case, somatic dysfunction would be a much more appropriate concept, or more as an holistic practitioners, and if body, mind, spirit, emotion, this type of approach, in this case, a more neuroscientific approach, trying to target non-specific effects would be more appropriate.
Okay, thank you for your, your contribution to the debate. So I hope that this sort of the ideas. Hopefully, this forms a building block to the next thing. So the next one we're going to talk about, moving from this and trying to think about the function, the person. This time, trying to think about things from perspective of clinical complexity. So I would like to invite Sonia and Christian to join me, please.
Hello.
Okay, and ladies first. So I would invite Sonia to start, kick off. So think here about sort of do we need to kind of think about 5 models? Kind of sometimes things hard to kind of implement. We're facing a lot of times very complex patients. People that come with persistent pain and other physical symptoms with a lot of stuff going on. Does it make sense to sort of continue that way, or there is a value into thinking about something simpler, more straightforward? And we clearly here thinking about complexity, not the straightforward, acute, never happened before, and you can perform a miracle with the other stuff. Sonia, what do you think? What's your view?
Okay, thank you. Well, in my opinion, I don't have the clue. I don't have any answer. But what I think, like Christian asked in his presentation, is about what we learned in the past. No? And I think all of us, we learn about simple models, and also they are still in the training programs, the simple models. But also with what we have learned in the last decade, or with the recent literature, is that the patients, that the body is not a simple organism. There is a lot already talk about that. So to maybe these simple models, like from a pedagogic point of view in trainings, if they are plausible, maybe they have his place, but to explain our interventions and to bring this to a clinical setting and to a research setting, it's quite difficult. In my opinion, it's difficult to isolate the effects of an intervention following a model, a simple model, also a combination of models like Christian suggests to us. Because in research publication, in recent publications, for example, about autonomic nervous system, trying to understand what is the effect of manual intervention in the body, there is a lot of controversy, because there is so many facts around the complex entity of a patient, the combination of a patient with a therapist, that is so complex that it's not easy to bring it also to clinical research. And if I think also from a clinician point of view, and I'm trying to think what the clinicians ask about or claims about research is to have applicability, to see the applicability of the research of the models and in their patients. And this is not happening. Why is not happening? Because we are not simple, and it's not so simple to find, I think, a common solution or a perfect solution in all this. Just to finish, I think I think we have to also debate that of course we have to have a critical view of the simple models, or maybe to research about new models, but we have to reflect also why we cannot go on, or why we cannot understand what is a model, or if we really need models to justify what we are doing. And in this sense, I think there are 2 issues that we should also develop as as osteopaths, together with developing or criticizing old models or simple models, and there is the thing that the trainings, the programs, the undergraduate programs, maybe should get more involved in this debate and the application of medicine-based evidence in the programs in a different way that we are doing, just to justify a dissertation or to learn the student or to teach the student how to make a dissertation, but to involve more different there. And then maybe we have to think of how to fit this model in the reality of the osteopathy. So maybe we have to find new methodological approaches that can explain this complexity.
Yeah, thank you very much. Actually, there's a very,
maybe I open a lot of them.
No, you can open the can of worms. That's absolutely fine. I'll just go back to you in a second, Christian. So a couple of points, actually, then I'll pass to Christian. You raised, first one interesting point, which is about, models and, the value of models. Arguably, models enable you to navigate the world, and a kind of useful thing, useful framework. But, models are there to be falsified. So you can think about, back to the kind of Copernicus came up with the heliocentric model at the time that we thought, there was a geocentric model, and, faced a lot of criticism and more than criticism. So I think models are there to be falsified. That's fine, and they're kind of important to help us to navigate the world. The second point is kind of interesting is, you talked about from an educational perspective. I remember, years ago, teaching clinical reasoning was always difficult to kind of get students to understand, actually, how do I deal with a patient? I have to think about, what's wrong with the patient, red flags and so on. Then I need to apply this, I need to apply that and so on. And some guys kind of, particularly at early stages of their clinical training, they were kind of at a stage or black or white, shades of gray, uncertainty. The mind doesn't like uncertainty. The mind tries to kind of, filter out uncertainty at all costs. So the question to Christian is, within all this sort of a complex swamp, of uncertainty, how do you kind of help people to make some sense of this and sort of enable them to navigate those 5 models? Do you do them in an integrated way? How do you do that?
Well, for instance, you touch some aspects about education that are really interesting, because teaching complexity, it's another thing to do. Well, maybe some aspects I described briefly in the presentation. I think today that I can teach just thanks to the clinical training, so in clinics with real patients. Because, for instance, I spoke about the decision-making drivers, okay? So some aspects I use, for instance, some provocation tests to evocate a pattern to recognize in the cows. And that emergent patterns help me to make decision, for instance, what type of touch and where maybe, or what type of movement I can use in an active patient approach. But if you use something like that with students together, it doesn't work, because if you use a provocation test in a non-symptomatic patient, does make sense. That's why I use some validated test, take it from the biomedical evaluation of systems to use as the decision-making drivers. Also, behind some subjective aspects of the daily life of the patient, to be the patient more involved. But for instance, that the changes in the objective examination of the systems functionality help me to find what kind of type of touch I can use to address some function. It's quite hard to teach to students without clinic. I can teach just in clinic, not, and in theory. They can. Sure. Okay, and about the complexity, you remember me now, your teaching and Professor Tyreman teaching about the Canadian framework, framework, and thanks to you, I read something about that in the past, and in my knowledge, complexity science model like that remember us that to achieve knowledge, to achieve information about the real world, about the relationship with the patient, we can do just remembering all the aspects, all the domain of the real world. And when the complexity scientists observe our work, the primary care work, they say that we have the simple domain, and in the simple domain, they, as an example, they put anatomy, they put physiology, and they also put the results of a single clinical trial. Then the second domain is the complicated domain, and when they give us example of the complicated domain, they speak about the guideline. A guideline can give you lots of information about the symptoms, about the condition, about the disease, not about the person. To know about the person, maybe with the disease, affected by a disease, you jump in the complex domain. And in the complex domain, you need an emergent pattern. And sometimes it's difficult to let a pattern emerge. So you have to do, you are in the chaotic domain, and you have to do some action to let the pattern emerge. And then you can recognize and you can program the treatment. And all of that is to avoid the disorder domain, to avoid the fall of the practitioner and the patient into the disorder domain. And when I think about the structure function model today, I think they are in the complex, between the complex and chaotic domain. Of course, if we think structure, somatic dysfunction as a cause of the disease, we are again in the simple domain. But I think we can do a little bit more, I think.
Yeah, and the Kinafin framework is definitely a good tool introduced by the late Professor Steve Tyreman, and comes from kind of a disaster management, and actually introduced to medicine, and then sort of found way to osteopathy. I'm very much, and as you know, I'm kind of the area that I'm particularly interested at the moment and working on a paper is on predictive processing. And I look these days at the patient simply from an individual and try to kind of understand that individual and how that individual constructs her own reality, and based on that sort of adapt what we can do as osteopaths. And there's a sort of a number of ways that I think we can keep it simple and enable us to sort of which is one thing I like, is to be creative in clinical practice, rather than sort of have to. Sometimes one thing scares me about 5 models and so on, and I'm kind of being critical about it, and it's sort of being a little bit stuck within that, and today I'm going to use this model or not. I don't think that way, and kind of I just navigate that world of complexity and try to kind of look for very practical ways. Can I surprise that system by getting the patient to kind of have a good experience? All right, so let's move on to the next one. Thank you, guys. I think it was a profitable discussion, and I think that sort of links very nicely to the next 2 participants, which are Paul and Oliver. So we're going to talk about what are the main epistemological challenges in these 2 also these models of osteopathic, structure function. Okay, so let's keep these not too academic, guys. Otherwise, everybody will go home. They're already home.
I have to
anyway,
disagree with Ollie. I think this is the hardest challenge.
Sure. Okay, so let's agree to disagree, and one of you who wants to start.
I can start. Yeah, I mean, I thought for the audience to at least explain what I took to mean the epistemological challenges. I mean, I took that to mean what are really what sorts of knowledge does osteopathy value? That's the first thing. What kind of knowledge is important for clinicians to use to make decisions? And then thinking about just the kind of knowledge-based challenges which are posed by the structure-function model. I mean, thinking about what we've heard from Christian this morning, wherever you are, in terms of what the epistemology speaks to me. I mean, apart from the small line of the biopsychosocial model, I mean, I really just heard biomedicalism. I mean, I heard kind of 4 models, and then the BPS model tagged in at the end. So I think the challenge so my position is such that we don't need 5 models. 4 of them they all share kind of biomedical positivist premises, which are unnecessary and are confusing. And I think the challenge comes is that most of these structure function models, they still prioritize clinician. I mean, it's about the clinician's knowledge, the clinician's skill, the clinician is the operator. And we hear very little, or there's very little room for other types of knowledge apart from kind of biomedical, structural, anatomical knowledge. There's very little room for communicative knowledge or relational knowledge or artistic knowledge or interpersonal skills, all these kind of things. It's still the structure function models cannot unchain itself from biomedicalism, and some of these things are incompatible. You can't really have a clinician can't go into clinical practice with 5 different models, many of which are contradicting themselves. It's cognitively impossible, and so I think there are some significant challenges. And I suppose, and it's not dismissed. I'm not saying there isn't anything valuable in some of these structural models, but I don't quite see why by having 5 of them or 4 of them, and then the BPS model kind of tagged at the end, I don't know why we just can't subsume the 4 kind of biomedical type models into a hallucinogenic or BPS model. So I've got some real issues with what we've heard tonight in a curious and critical and friendly way.
Mm-hmm. I knew that.
Thanks, Ollie. Now I have to try and disagree with you.
That's all right. That's what we love.
I think it's how we define structure function. We've had a little chat on the way, and I think it's important to see it as a guideline for clinicians and as a principle. And I think the main limitation when we get into these discussions of biomechanic or psychosocial is the dichotomization. These are not 2 different elements. Separating them in 2 separate worlds is artificial. Reality of world is complex and everything is linked together. So when we attack the problem of structure function, if we get into this debate, it's because we're not defining function appropriately. Because in itself, structured function is a principle no one will argue against it. Function is dependent of structure, and if you do certain elements, it will change the structure. And I think the basic principle that's there is something that's very common to all osteopaths. Now, when we define function, it's to what extent will it go to? And as an epistemological cause, how does it link to the structure? And in what ways it bidirectional? In other way, is the function also our social interactions and the way I work, the way I sit? Is an osteopath work also about addressing these issues? If it's the case, that means the function is not only physiological functions within the body or the organs, it's also the way the body interacts with the environment. If we broaden the sense of function, then there's no incompatibility between structure function and broader models. So I think that's maybe a way to tackle the problem is really have us define what we mean by structure function in this link, and not see it as a model, but as a more of a principle. And then we can work around there with lots of different models that make sense and have different insights, and that can be overlapping one with another. I didn't go over the 5 model approach, because I tend to agree with Ollie, where for me, it's epistemologically, it's not really a model. It's a framework, it's a way of working. It's a really good framework because it's easy to teach and have people consider different physiological bases to understand the patient. But a model in itself is a way to model reality. It has to predict something. So it has to be able to steer into an interpretation that we admit is reductionist by definition. And for that, we need to be able to measure it. And the 5 model in osteopathy doesn't predict anything. It's just a framework of what we can do, but it doesn't say what we choose and what it will bring to. So on an epistemological basis, it's not really a model. It's just a tool, an educational tool to help us move forwards and not forget something. It's a checklist. Maybe I'm a bit harsh with the model. But
I see it the same way. But but playing a little bit of devil's advocate here, and actually, as a result of conversations I had with colleagues in other countries, the 5 models. There's also one thing: the 5 models are part of the WHO, document, and in some countries, for the profession to become regulated, that was a way of also sort of helping kicking the door and kind of to open the door, because what's unique about osteopathy, and people kind of argue that what's unique is the 5 models, and I entirely agree. I don't use them, and I don't think that is kind of useful to.
Yeah, it's not a zero-sum game. So if you prime, and I totally get the regulatory argument. I get that there are osteopathies in corners of the world which are still kind of struggling and striving with professional recognition, and I understand those challenges. The challenge, though, is that if you prime students with these models, which really just engender unhelpful beliefs and behaviors, which we know lead to poor outcomes. We know that clinicians' beliefs influence patients' beliefs. We know that patients' beliefs influence their decision making in terms of the kind of treatments they're going to choose, whether it's more invasive interventions or more conservative. And so the challenge is that to say, well, these models they're important from a professional identity sense. I understand that argument. The challenge is that they actually do more harm, because they begin to ingrain from a very early stage a certain way of thinking, which pretty much the entire field of healthcare is trying to move away from. And that's the challenge. That's why when we get students that come out after 4 years, 5 years of studying osteopathy, they find it really quite difficult, because these models don't map up to the complexity of clinical practice, of reality, and they suddenly find themselves in a sticky situation and have to navigate and either sign up to CPD courses which don't give them the answers either. So I don't think they're just harmless tools that actually, it's okay if they're going to float around. I think they potentially begin to shape clinicians into ways which aren't ideal.
Mm-hmm. But do you think that, for example, it's your hobby horse, and your area of research, do you think that the biopsychosocial model is also?
No, of course not. No, of course not. No, of course not. And I'm not arguing, and that's of course not. But in terms of progression, the BPS model has been progressed. I mean, there are people writing papers on the BPS model, and it accepts its limitations. And like, whether it's the evidence-based model or any other model, none of these models are perfect. That's the nature of a model. But in terms of what do those other 4 models really give us? And they give us some therapeutic targets to deliver manual therapy, really. And I just think that's fine to have kind of biomedical targets for manual therapy, but they can all just be subsumed into a more general evidence-informed model, BPS model.
Okay, cool. All right, thank you guys. Fascinating.
Sorry,
say Paul.
It's just it does bring us to a place where do we go from here? Because the 5 model was a way to actually set up standards in a simple way. And what I think we're saying here is simplicity doesn't necessarily help. It might help on an education to make people feel comfortable, but if it doesn't relate at best to reality or give different options, then we're locking ourselves in a system where we can't progress anymore. So I think the main message is saying, okay, well, how can we look into this model and put it up to challenge and use it as a framework, but leave room for it to evolve, to have different types of thoughts and complexity brought in? And how do we bring this into education so that progressively students learn that our interpretation is related to complexity and that we can move through different models. So I think on an epistemological point of view, frameworks are good, but they must not lock the system into a view and prevent from evolving and helping us through. And I think that's the challenge we have, not only for the 5 models, but for many things in osteopathy.
Sure, and that's what we kind of argued in our editorial. In fact, it's this thing about person-centered care that arguably was something at the beginning of osteopathy. It's been there for a while, and then we kind of exactly, and we kind of lost
an
it
additional
because
element, and I think we have so many of them, and it can really enlighten our profession. And also sometimes we forget that clinical experience brings out really lots of skills, and many existing models, if we look, really relate to what clinicians do, and they're really good at doing things without knowing it. So sometimes these models are only to put forwards some skills that we don't communicate well to the outer world, and that we don't value our profession at the height with which we could. So I think these elements of complexity, theory sometimes really helps value what people do on the basis of their clinical work every day.
Sure, and that's what Oli before with his PhD talked about professional artistry. It's the end of the day. You kind of generate. There are different forms of knowledge. Maybe they're not sort of valid in what we do. And I think we need to kind of ask the big questions and change and evolve as a profession. Okay, thank you guys. I might sort of ask you guys to come back. So let's move on to the next one, and I'll ask Tameem and Patrick to come along, please. So now is the sort of, think about, maybe we take it to the next level, which is the research, and how do we kind of manage the burden of proof regarding the structural origins of dysfunction, the big somatic dysfunction thing. So, I would start with Patrick, okay, if you're happy with that. And then, Tameem to kind of
Thank you for moderating and
challenge.
First of all, I want to thank Christian for a nice presentation. I think a lot of things that we wanted to say have already been said also by the other debaters. How can we manage the burden of proof is, I think, by doing more research, I think. Refine our ideas, be creative, and maybe also follow the logical step we proposed in our item editorial, and that was kindly presented also by Christian. Let me say also that the structural origin of dysfunction can be sometimes obvious. So when a patient comes into my practice and present themselves with a severe arthrosis of the knee, for instance, then it is obvious that the structural origin is very clear for dysfunction, but it is not always that case. It can be very complicated, and I think what Paul said about complexity as its role also here. I think that we have to look at not the linear way of looking at dysfunctions and its structural origin, but also take into account more complexity way of thinking, and also in doing research. That's my point of view.
Mm-hmm. Okay, I agree. Tameem, what's your view?
I think from the beginning of osteopathy and under Stern was talking more about the mechanical origin of the dysfunction, and his famous quote about find it, fix it, and leave it. So the idea about fixing something. So this is some of the structural origin of the dysfunction. Then if we think more about how we define dysfunction, so what is the definition of dysfunction? Is it a somatic dysfunction? So we going back to the mechanical model of TARD, to the tissue asymmetry and tenderness and all this stuff, or it's more global than structure origin. So it's more as we said about biopsychosocial model and also other models. But I agree that structure can be apart from the global or general picture of the presentation of the dysfunction. So as a framework, we have a structure, and we have also other models that we can use for our patient for examination and treatment. And it doesn't mean that we only doing hands-on to treating this dysfunction. So we can use this model as giving advices, giving a structure, working on the person itself, not only doing hands-on to treating this dysfunction.
Okay. Yeah. Thank you very much. So the big question is, at the end of the day, for you guys, kind of wrapping up this, how does all this stuff inform, your clinical reasoning and your patient care? How do you how do you wrap the whole thing? What does this mean?
I think it depends on the patient. So if you have, like, as you said, acute patient with just ankle sprain or local part injury, so we can go for more mechanical or structure origin, and think more about how we reassure this patient about the biopsychosocial model. But for the complex patient multifactorial problem we have, so we can navigate between all these models. We can doing hands-on, we can giving exercise, we can support the patient. So that's it.
Okay. Yeah, Patrick, have you got anything to add?
Ultimately, there is also a burden of that we as osteopaths deal a lot with structure, and we like to have structure, anatomical structure in our hands. For the practice, the main thing is that not to think in a linear way of cause and effect when dealing with dysfunction of certain anatomical structures, and that we have to take much more in account and think about it in a more complex way. That is thinking for very important for practice.
Great. Thank you, guys. And I actually would like to invite Francesco just for one, to follow up from this debate, if you don't mind.
Yeah.
So if you guys go, I'll ask Francesco to come along. Just so what I want to kind of ask you and sort of value your opinion on this is, from actually a neuroscience, placebo perspective, and so on. And actually following from Patrick's kind of point about having the structure, the anatomy in the hands, and so on. What's the role of kind of non-specific effects in the whole osteopathic treatment, and how relevant is that? And does it fit sort of the these osteopathic models kind of very arguably reductionists?
So thank you, George, for putting that up. Because it's just one of the elements that I was thinking while carefully listening to all the interventions, all the speakers, and all the speakers actually who brought something extremely interesting into the discussion. Now, usually this is something that is demystified. So everyone knows that touch is relevant. Everyone is touched, probably this period less than ever, but generally is touch, and it's not the case that probably we are going to have some psychological effects. Yeah, you can self-touch, definitely, but so the relevant element is the fact that in terms of the patient approach, so how we approach the patient, there are definitely some elements that are specific or non-specific, and other elements that are specific. So specific treatments obviously are specific, so requires some elements that are learned throughout the osteopathic training. But at the same time, there are definitely other elements that are part of the touch, but not only the touch, because actually when we approach a patient, there are all the non-verbal or language, the placebo effect within the relationship with the patient, the obviously context effect, and all the elements that actually are related to the non-specific osteopathic effect. That might be in common with other also manual therapies, as well as with other general holistic, between quotes, holistic approaches. So one of the things that it might be relevant to discuss is, from one side, the neurobiopsychological effect. I would like to add the neuro on that side. But on the other side, also the non-specific element of the, if any osteopathic model might be used in the clinical practice so far, because at the end, when actually a patient comes, I'm not entirely sure that we are putting ourselves in the context or in a scenario where we need to strictly use one model and then pass to the other one and then pass to the other one. I mean, as you teach me, George, it's going to be too much energy for the brain to control. It's extremely too expensive.
The free energy principle.
Exactly. So that means that actually we are moving far away from our focus, that is obviously the patient, and therefore it's kind of difficult in a way to strictly being conscious of what actually the model we are using, and in particular might be not so optimal in terms of effectiveness of the treatment that we are providing, being extremely linked into just one box of the model. So I see the model as a general theoretical framework, but in the clinical practice, actually, they are fully mixed, absolutely fully mixed. Now, the added value into all these points is related to the non-specific effect. That has been demonstrated. I mean, the touch, non-specific touch, or specific affective, or the affective touch might produce a distinct effect within the brain, in particular into those areas that are important to the perception of self, so the insula and all the related areas. Therefore, if we consider it from a clinical standpoint, the patient has definitely an altered mechanism that implies the insula to use those input from the body in order to understand better what is the reality around us. That means that if we can manage the reality around the patient in terms of improving into some specific elements, into the contextual factors, or the way in which we approach the patient, with the way in which we touch the patient, because actually it happened for everyone, that we predict to apply a specific clinical pathway, but then during the first seconds of that approach, we have the feeling that pathway might not work. And that it's immediate and is not specific. So it depends and possibly belongs from something that is not specific, that is related to the fact that actually we are touching the patient in a way that he reacts in a way that actually is not directly non-specific, because we are not starting to apply the technique, but we approach the patient, we touch the patient in a way that the patient reacts that actually he doesn't want, he or she doesn't want. So we need to be more carefully, we need to have more attention on that elements, And we need to have more elements in order to understand what might be the most appropriate way in order to control non-specific approach and obviously non-specific effects. There are several, let's say, evolution in that sense. We are putting forward 3 or 4 papers on that context. And also Gian Domenico D'Alessandro is one of the leading guys, from Italy, is one of the leading guys that is working with us for this topic in collaboration with another guy from the National Council of Research and the Boston University and Boston Children's Hospital and Harvard University, in order to understand what are the contextual and non-specific elements that might be useful in order to better manage, to better tailor the clinical practice for the patient itself. So back to your question, is yes, we need to take into account that in this moment we are not let's say rigorously taking into account for the non-specific effect, but actually the majority of the clinical practitioners do that by instinct. So we are just trying to understand what is that instinct and to list category. I don't want to say the brutal word categorize, but study what is that instinct in order to understand better how that type of approach might be of help of a more structured and more specific way of treating the patient.
Great, right, excellent. And just, on the non-specific effect, without arguably could be considered as such. I was going to ask a question to Tameem, and then I'll ask Rafael, if you don't mind, just to come along. Which is, think about, one thing on the whole kind of approach, which is the religious, spiritual side of things. How much do you think that is important? How much does that contribute? When we know each other, we know from our kind of discussions and so on. In this environment working here, that's clearly a very important aspect, either religious or spiritual. But how much does that play in your treatment, in your approach, in your patient's belief? And then we kind of move on to Rafael on that sort of spiritual side.
Yeah, I think it's very important for the patient if he believes that the problem maybe he has is coming from the God. So he has this problem from the God, and he thanks his God for this problem. So he doesn't shows any angry or being in situation to say that it's not good for me. So he accepts this problem and he try to convince himself that is okay, thanks God for this, and I will be okay. So this is the same as we doing also in neuroscience education. So we telling the patient that it's going to be okay. So don't worry, it's going to be okay. So he has the same message from the God if he is religious and he believe in that. So this is will be okay. Will be good for me. So that will affect his perception and also his pain level.
Yeah. Okay. So, Rafael, it's one of your areas of interest and expertise, in particular looking at, IT still kind of a, spiritual dimension. And so I would like your view on how much that plays, and actually from your paper on the biopsychosocial spiritual model, how much does that play a role in osteopathy? And then I would invite Oli to join us again, just to kind of debate a little bit of, does the BPS extend to that? Is it important to the spiritual side? What's your view?
Well, we'll have a full webinar next time to answer this question. So
yeah, you can advertise your webinar.
So the thing is, there's a lot of studies in cancer care, of end-of-life care, that shows, like you just said before, people tend to make sense of what they are going through, and the brain doesn't like uncertainty, so we have to make sense. So this could be applied to musculoskeletal complaint, but we have no clue about that. So that's why in our first paper that we wrote with Francesco and Jerry, we thought that including this spiritual dimension into the biopsychosocial model could be a good opportunity. First reason is that there's a couple of recent papers that shows that the spiritual dimension has direct and indirect impact on the physical body. So basically, it's not related to one specific religion or one specific type of spirituality. To make it the most simple possible, it's just people who tend to believe in oneness, just believing in something that is bigger than itself. This type of people have a better quality satisfaction in life. They have less chronic diseases, and they comply with treatments much better than people who does not have this type of belief. So if we as practitioners in osteopathy, we are pretending to provide holistic care, patient-centered care, being aware I would say not for in routine care, not for every patient, obviously, but for people who suffer from chronic conditions, for people who suffers from post-traumatic stress disorders, for example. So this type of people, you know that better than me, that this type of people that had to cope with very stressful conditions. Probably these stressful, these coping behaviors has some consequences into the musculoskeletal system. So touching the body of this type of people might not be the same as people who did not have to cope with this type of very stressful conditions. So this is just an hypothesis, just a presumption. And since we have a lot of people, we'll be more than happy to share this type of discussions. And I know that there's a couple, I'm supervising a couple of final year dissertation in Switzerland with Paul, and in France at CESO. So just to explore this field among patients, among practitioners. So hopefully we'll be back in a couple of years with more data to support these current presumptions.
What's your view, Oli, on the sort of extension of the model?
Rafael.
Sound.
I've been meaning to read it. I think in terms of, if it's anything that's important to the patient, then it's going to be important to the clinician. So if the patient holds strong spiritual beliefs, then and they're relating those beliefs to their current kind of level of suffering or their kind of pain experience, whatever it might be, then that's got to be of interest to the clinicians. And so if it's valued by the patient, then the clinician needs to understand it and to some extent value it too. And so I certainly don't see them as being incompatible. And if the biopsychosocial model proclaims that clinicians really try to deeply understand the patient's values and that embodied relational kind of experience, then of course spiritual beliefs, like any other set of beliefs, will be part of that remit with the clinician, whether it's pain beliefs or fear avoidance beliefs or so I don't see there being a problem at all. In terms of clinicians using spirituality as some intervention, then obviously that's another discussion to be had.
Yeah. Okay. Great, guys. So just to wrap up, I would invite Christian back and also Paul, and we'll just sort of go through just some of the points here, kind of, and we can wrap up and, and finish the evening. So, Paul, you've been kind of answering some of the some of the questions online. Great stuff. So what's
we've got great inspirations for the future.
Yes, some good research questions. Yeah, excellent.
I think it really shows that different views of people show how complexity is approachable, and from our experience, I mean, people are talking of loads of different models and approaches that maybe we haven't seen in our courses, but which really relates to our work. And I think we can see that it's not so difficult to integrate that in our way of seeing. It's just about understanding, not being frightened of the unknown. So yeah, I found it interesting. Jeremy really got into the variability model, which is more models that have been emerging in understanding systems in variable context. And he's saying, well, the somatic dysfunction, it's a good approach to be able to see it through. And I totally agree. But I think we really need to think this through a critical aspect and insight, and put this back into a context of how other people see what we do. And we need to be able to formulate things that it makes sense not only to us, but also to others. And I think here, just with the forum, we can see, I think we're capable of doing this. We're living a period where osteopaths are building up their arguments. And I think we're up to the job. It's challenging, but I'm quite optimistic. I think we can do it. As long as we don't hold on too much to models that are not understandable by others, but we really feel, okay, but I like this model, what I do in my clinic, but how will I reword it? How will I put it in another context so it makes sense to what we know today? And there's always solutions, and then it evolves into something that's better. So,
and some of the comments, there's a couple of comments here about does the patient care about the model you use? At the end of the day, the patient wants, comes to see you to have an improvement of their condition. If you kind of use X, Y, or Z or ABC, honestly, it doesn't matter. Do you need to communicate that kind of approach? I think, one thing is how you navigate, how you kind of, how you get there. And the other thing is what sort of information you pass to the patient, because, as Ollie kind of talked about during his presentation a few days ago, is, you can sort of frame things in a very negative way and kind of lead to kind of unhelpful beliefs that once there, that's kind of very hard to kind of get rid of. It's almost impossible at times. Okay, and there's a sort of the whole concept of somatic dysfunction, which is still at the heart of a lot of stuff we do. But some people say it's useful, but what it is, how do we research that? And for Christians, it's an interesting thing. I think a point that is important to raise here is that when we start talking about models, some osteopaths immediately look at this from, here we go again, we're talking about just osteopathy as musculoskeletal care. And clearly, for a lot of guys, it isn't, because, people treat patients across, the lifespan from preterms to the elderly. And some guys say, no, it's not my area of intervention. And some other guys, no, I'm very comfortable being an MSK practitioner. So, Christian, how do you kind of conciliate this sort of, some ways, it's very much in the musculoskeletal stuff, but recognizing that other times, we clearly operate in different areas, and I think it's important to celebrate that sort of diversity in the profession.
Well, first of all, thank you for the debate. Lots of insight to reflect on and to guide some research agenda. Of course, models are models and are useful to speak about what we do. Then what we do is what we do. I don't know, I find useful to describe all the different approaches that you mentioned now, not just the musculoskeletal. For instance, to describe to a student that how it could happen that in that patient we improve a range of movement, but without articulate, maybe doing some lymphatic pump in the thorax. Why improve it happens? Or sometimes doing some interoceptive approach together with intentional breathing or mindfulness could improve a range of movement. So some musculoskeletal improve with something totally different. I find useful describe that kind of stuff with the structure function models. But if we found something more useful and more, let me say, shared, could be the biopsychosocial model that, in my point of view, is a part of the 5 structure function model. It's nothing new. It's not a new model. It's from 1970, so it's nothing new. Shared in medicine. But if I look at the definition of a theoretical model, I found again that the model must define distinctive of a profession, because if you don't describe a distinctive way of response to health needs, doesn't exist the profession. So that's my point of view. Have we got a model, maybe the biopsychosocial model, describe the proper distinctive way of osteopath to do something that other profession could do, but in a different way? So you do in your way, and you describe with your proper model, maybe a shared model, but that can describe your point of view, your position, and your role as a distinctive role. You exist. If not, maybe you doesn't exist.
Sure.
That's
and
not,
it is actually, carry on.
That's not my point of view. That's the definition of the model. So
sure. And that's an important point. And actually, there's a couple of comments here about that. One from Gerard, that maybe our obsession to find and define models is more related to find a way to define ourselves and be able to create a kind of distinct professional identity than a real need to approach our patients. And Alessio also mentions the same thing. And, and an early comment from Luis Horta along the lines of, the 5 osteopathic models found way on the WHO from political reasons, kind of. And then we left with that. And that's in some countries, as I go back to kind of what I mentioned before, it kind of useful, helped. But, is it really helpful? And we can sort of, I guess we could sort of debate for the whole night, and, we would go to some place. And I think, we kind of reached a different place from where we started today, I think. And it's been quite fascinating,
I agree with all of it. I agree with Gerard, for instance, about the obsession. Maybe sometimes it is an obsession, but for instance, in the Italian history of osteopathy, for instance, in the political process, there was not the politician that asked us to define our role in a distinctive way. That was the university, the scientific committee that asked us to define in a different way from other that use manual therapy. No, it was not politicians.
But, but I guess they're right, because if you're in kind of a you're doing a higher education program in a university, and you need to have some kind of professional knowledge, some kind of knowledge that is unique to the profession. Otherwise, I say, well, what's the point? And I think it goes beyond to, for example, in the UK, the 1993 Osteopaths Act defines osteopathy as what an osteopath does. And for a long time, that's, for a lot of osteopaths, my experience many years in the UK was, if I do things, if I do ultrasound, but I do it from an osteopathic perspective, that's osteopathy. And say, is it? And I think, sometimes we feel uncomfortable about using stuff from other professions. Ultimately, it's a sort of about providing the best possible and more effective and safe type of care. And there's no longer anything that is unique, I guess, despite the fact that we can claim, our models are unique. Are they? And that sort of can create a lot of uncertainty in osteopaths, when you introduce the BPS and people say not enough bio in the BPS, because bio is biomechanical, isn't it? So, it's a kind of interesting. And actually, I would just to wrap up, and this one guy, Juan, here asks, where is Chantal's opinion? So I'm going to invite Chantal to come along, okay? Chantal has been kind of hiding, okay? So I'll leave Christian and I'm going to ask Paul to give way to Chantal. Chantal, bonsoir.
Hi, sorry, I
Where are you?
guys from my country that are asking my opinion right there.
Exactly.
So, yeah,
So
sure
go ahead, come on.
I'm quite happy to listen to Oliver before, because it seems like a bit what I was thinking, and it's true that here with the regulation and university program development, we were stuck with the WHO 5 models. So they asked us to use that, but we were not comfortable to use that to define our profession. So we tried to move the focus a bit on something else that distinguish osteopathy. So we tried to move. We said, yes, there's those models. Each osteopath modulate them to answer the complexity of their patients. But we moved the focus more on distinctions like the way we analyze the reason of consultation, clinical reasoning, that it's more specific to osteopaths, and the specificity of our palpation too. So that's a bit the way we navigate through. Yes, mention those 5 models, but try to bring the other academics to another view of the osteopathic as a specific and other profession. Yes.
Yeah, that's good. So it was good to see you here, and to contribute to the debate, because as you said, sort of regulation in Canada and the kind of advent of academic programs at university level, at least in the French side of Canada, isn't it? But it's an important kind of it's an important step forward. Okay, so I think we sort of had an interesting debate. So I would like I would like to thank I'll bring Christian again, because at the end of the day he's the guest, and then we can't leave him aside. Christian, just come back just to say goodbye to our our viewers. So first of all, thank you very much for your presentation, contribution to the debate, and thank you to all my colleagues who come for their kind of great participation. So if you want to say something, please.
Thank you for your moderation, first of all. Thank you, George.
It's okay. My pleasure.
Thank
I had
you
fun.
all.
That's the important thing. I like kind of playing devil's advocate.
Thank you all the other guys
has been
participating on the debate. Thank you all of you. Have a good night.
Yeah. Okay. So thank you, guys. We're going to have a few weeks without, a couple of weeks without webinars. The next one will be on the 31st of May with Rafael on body, mind, spirit. Okay. So have a safe evening, guys, and for those guys living in countries where Friday is not holiday, weekend, have a good weekend.
See you.
See you. Bye.